So moving on with child health and healthcare seeking, the next presentation is entitled The Validity of Maternal Report for Care Seeking for Childhood Illness. The presentation will be done by Micky Ndolvu. Micky is a principal lecturer in clinical medicine at Chainama College of Health Sciences in Lusaka, Zambia. His medical training was at the University of Zambia, and he has an MSc in epidemiology from the University of Witwatersrand, and he's been involved in numerous research projects in Zambia, particularly in the area of child health and malaria. So, Micky.
Good morning, all, and it's a pleasure to be able to talk about this study. This study was done through the Institute for International Programs at Johns Hopkins University, in collaboration with Tulane University and Chainama College of Health Sciences in Lusaka, Zambia. It was funded by the Bill and Melinda Gates Foundation. Seeking care from skilled provider is the first step in assessing correct management of illness, whether it's childhood illness or adult illness. National population-based surveys have been used, has already been mentioned by Melinda, such as the DHS and the mix to measure demand and access. But often the question is the validity of the measurements that are used. So there's need to ensure that the data collected through these surveys, especially using recall from mothers of caring for children under 5 is concerned, we need to be sure that the data collected is accurate. So this study designed the study to assess the validity of mother-reported care seeking for childhood illness captured through household survey. The study site was in southern part of Zambia, a district called Choma. It's about 17,000 inhabitants, mostly are rural-based. The study population included a random household of households with children less than 5 years of age, and also providers offering child curative services. This be in the public sector or the private or informal sector. So the study site included 3 health facility catchment areas that are rural-based and 1 urban, but the population was almost the same, since most of the inhabitants of this district are in the rural setup. In terms of the methods used, this was a prospective cohort design, and we recruited children and healthcare providers at the beginning of the study and followed up for about 4 to 6 weeks, at which point we performed a household survey looking at whether the children that were recruited at the beginning of study had any illness, and the illnesses we looked at were fever, diarrhea, or suspected acute respiratory infection in the past 2 weeks. This was based on the same questions that are used in the DHS and the mix surveys. In terms of the procedure, we provided children with barcode cards and providers with the health care providers with phones that are able to read these barcodes. In addition, we also provided the healthcare providers with specific color-coded ribbons that they were supposed to distribute to every child that they had an interaction with, and if the child was seeking care. This was to ensure that every child that they came in contact with was either, we could be able to document that they actually sought care from these providers. In addition, we also included the routine data collection system at the health facilities. This is an independent system that is run by the Ministry of Health at these facilities. But I should mention that these, of course, were not existing at the informal healthcare providers. In terms of analysis, we compared the mother-reported care-seeking events, which we treated as a test, and compared against the provider-documented care-seeking events, which we considered as the truth. And we calculated the sensitivity, specificity, the PV and accuracy of recall. This was stratified by urban and rural health, rural setup. We corrected for misclassification and non-participation. We used mixed effects model, and we selected to use the health facility catchment area. That's the population under which the mothers and children often seek care, and that has been determined by the Ministry of Health through the districts. And this was used as our random intercept to correct for clustering. So we were interested in 3 outcome measures: any care-seeking event, care-seeking at skilled provider level, and also source of care, that is to categorize by the type of health provider. We see that we screened about 547 children in the rural and 537 children in the urban setup. About 30%, 40% reported at least one DHS illness, and you can see that up to 70% of mothers reported having sought care for the child who was sick. The proportion of illness mother reported seeking care was as high as 90% for those that reported having sought any type of care. In terms of participants and event tracking, we were able to track 97% in the rural setup and 88% in the urban setup. So we were able to capture all this at the beginning and at the end of the survey. Here, this slide shows the sensitivity, specificity, and the accuracy of these measurements. So you can see that sensitivity of mother's recall was quite high. Specificity was moderate, and accuracy, that's the area under the curve, was acceptable. It's quite good. But what does this mean for population level and individual accuracy? We see that there's a blue line here. It's quite faint, but I'm sure there it is. This is the perfect measure if the population behavior is as good as reported. And we can see that when the underlying population behavior the prevalence is low, these methods tend to overestimate the actual observed behavior. And at the same time, you see that at high prevalence in the underlying population, it tends to underestimate the measurement. We also looked at any association with demographic factors or any other factors that would explain the accuracy. We found no association between accuracy and demographic characteristics, such as maternal age, maternal education, number of children in the household, and income. However, mothers underreported seeking care from traditional practitioners. Of accurate reporting event compared to mothers who sought care from government facilities. And also, it was noted that mothers of children not taken for care had lower odds of accurately reporting the events compared to mothers who sought care from government facilities. So what are the key findings of this study? Firstly, sensitivity is high with reasonable specificity. Though sensitivity was slightly lower in rural areas due to underreporting of care seeking with traditional practitioners. And specificity was reduced by overreporting of care seeking from government facilities. So we surmise that this could be due to some kind of social desirability bias, where if a mother who had a sick child did not take the child to a facility, they would still want to report as having taken. And at the same time, for mothers who took their children to traditional practitioners, may not feel very proud of themselves when they know they should have taken to a trained or a skilled worker. In terms of limitation for our studies, we had very few private sector events, few reported cases, and fewer were documented. Then there was also inconsistency practiced by or compliance by pharmacies. By the way, in the study, like I mentioned earlier, all providers were recruited. So for urban, where we had private pharmacies selling drugs, and we thought that mothers could directly go into these pharmacies to try to get medications, we also included them in the study and provided them with an ability to capture these events. But unfortunately, the compliance from these outlets was quite poor. Then also shops in Zambia, some shops are able to sell things like paracetamol or aspirin. So mothers tend to get straight into these shops. So we tried to include these shops as well. But unfortunately, again, due to a large number of these shops, it was very difficult to pull them, all of them into the study. Then we also had issues of imperfect tracking of events, where a provider could have seen a child but not given the tokens, so it was difficult to validate. Or also the phone may not be working because, especially for the rural-based providers, they may run out, the battery may run down, and are unable to capture the scan, to scan the token. Additional register review. This was kind of a way of ameliorating the problem that we had in that limitation, because this was an independent system used by the facilities. So they were able to capture this, and we used the data from that source to try to validate what we were seeing on our study. Okay, this is a nice picture of the research assistants that were involved in the study, without whose effort would not be talking about this study today. But I'm sure you can see a familiar face in the right side of the picture there. Emily, thank you very much for your time.
Questions for Dr. Ndolvu?
Well, it's just looking at a picture. If they had looked more like traditional healers, perhaps they would have reported something different.
I beg your pardon?
Yeah, your interviewers don't look a lot like traditional healers.
They
so
don't look like. No, these were research assistants.
Yeah, that's the point. That's the point.
Yes.
So they will more likely report to those kind of people that they went to the clinic than reporting that they went to the traditional healers. So if they had looked like traditional healers, perhaps they would have reported differently.
Yeah, I agree. I'm sure you. If I'm getting you correct, you are suggesting they could have had some effect on the behavior of mothers in seeking, on reporting. Well, it's a possibility, yes. Do you have any way you think that could have been improved? dress these guys like traditional healers. Yeah, but I agree with you. It's a difficult issue, especially when you take out people from urban settings. They are in school, and these are my students apparently at the medical college where I'm teaching. So yeah, it would be an influence on how mothers would respond. I agree.
Other questions? Oh, yes.
Thank you so much for that. Were the providers trained to keep records on the care-seeking behavior, or was there no training of the providers to keep those records? So I'm wondering if we are assuming that the providers' records are, or the mother's recall is what we're testing, or the mother's report is what we're testing, and the providers is what is the truth. How confident do you feel about the accuracy of the provider reports?
The providers were trained for 3 days in the use of the phone to capture, to scan the cards that the mothers would bring. And we had separate trainings for those in the formal sector who have about 12 years of education and went to college. Then we had the traditional practitioners who most of them haven't been to such arrangements. So we had different training for the two groups, but we made sure that they were able to capture events. Yes.
So do you think that if we're comparing these kinds of results about the validity against what the validity might be with DHS data or other kinds of data, that there might be a difference if, for example, these providers are trained to capture that information, but generally providers aren't trained to capture that information?
Well, there would be, but maybe before I go to that, I think I showed a slide that most of the mothers who reported having sought care, actually over 90% went to skilled providers. So there was only a very small proportion that went to see these traditional providers. So the effect there, I think, would be minimal in terms of the two levels of the two types of providers with very different education and background in terms of being able to capture the events. As to the other question you have asked, yes, I think that it would have an effect if we don't train the providers well in terms of capturing the events.
Emily?
Just a point of clarification on that last question. So we were interested in the validity of maternal report, not necessarily the validity of what the providers were doing. So we're just using the provider documentation as our gold standard for assessing how the mothers performed. So definitely the work that we did would potentially change the providers' behaviors in documenting these events, since that was kind of how the study was designed. But we wouldn't expect it to change the mother's ability to report. And we actually did assess whether or not these tracking methods might potentially influence mother's ability to recall by comparing those documented events that that providers documented with the scan or with the token versus those that we got purely from the register, which was just the standard of care in the setting. And there was no variation in the accuracy of report using those two different methods. So we feel fairly confident that the study design itself did not influence mother's accuracy of report.
Okay, one last question.
Hi, thanks. I just wondered, how strong is the private sector in this area, and do we think the results would hold in, say, a place like Nigeria where the private sector is a lot perhaps more robust with many different types of private providers? And just curious, I don't know this part of Zambia, how strong it seems unexpected that there was so little care seeking to any private sector sources.
I think we were able to enumerate just about 5 private sector outlets, and that included the pharmacies that were. But in terms of medical doctors who are providing care for profit, it's very low. Mostly it's the public or the government facilities that provide medical care in this district.